Hello, my name is Joy Ashby Cornthwaite, and I will be your host today. I'm a certified diabetes care education specialist in Houston and a volunteer with Cities Changing Diabetes Houston. Pregnancy marks a time when the awe of new life collides with the excitement, anticipation, and perhaps a healthy dose of fear for women living with diabetes. The added layer of managing a challenging chronic disease can seem very overwhelming. Intercentering, a prenatal care approach designed to give women more support and spark engagement in self-care building, health checks, conversations with their clinical teams, and more importantly, shared experience with their pregnant peers. Today, we're here to discuss this approach and how it reduces the economic and societal costs of unwanted pregnancy outcomes, particularly for women of color. Today's episode is coming up right now. You don't want to miss this. Before we begin, a gentle reminder, the content shared during the MyDiabetesHQ live broadcast is neither intended to be a substitute nor advice for diagnosis or treatment. Always seek counsel of your physician or other qualified health provider with the questions you may have regarding your medical care. This weekly broadcast is developed and produced by Cities Changing Diabetes volunteers in Houston and Philadelphia. Our two cities are the U.S. members of a Novo Nordisk funded global network of 37 cities, welcome Naples, Italy, working to improve diabetes prevention, care, and management all around the world. You can learn more about Cities Changing Diabetes by going to citieschangingdiabetes.com. The purpose of the MyDiabetesHQ Live is to help people living with diabetes and their support teams. I am joined today by our guest, Larissa Estes White. Good morning, Larissa.
Good morning.
And Dr. Annette Gadabeku.
Good morning.
And Serena Valentine, CEO of Core Initiative and lead of the Houston City Changing Diabetes Peer Support Network. And Dr. Gadabeku, welcome to, I think, your 5th episode.
Maybe, I think so.
And Larissa, welcome to the first of many, I hope.
Thank you.
Awesome. And if you both can just introduce yourselves and tell us a little bit about your passion. I think everybody knows Serena and I, but let's start with you, Dr. Gadabeku.
Yes, hi, I'm Annette Gadabeku. I am Associate Professor of Family, Community, and Preventive Medicine at Drexel University College of Medicine, Assistant Dean of Community Health in the Office of Diversity, Equity, and Inclusion, and a Medical Director of Adult Medicine at Philadelphia Fight Community Health Centers.
Excellent. And it looks like Larissa's going to be back with us in just a moment. So, so Serena, tell us a little bit about you and your passion.
Okay, my name is Serena Valentine. I'm the Executive Director for Core Initiative, nonprofit here in Houston, Texas, and we focus on health education. My passion, of course, is going through things in life and you don't know what you're doing. So it's better to know than not to know. So that's my passion.
Excellent. So now that Dr. Gadabeku and Serena have introduced yourself, Larissa, it's your turn.
Yeah, good morning. My name is Dr. Larissa Estes White. I am a public health professional out in Oakland, California. And my work currently is looking at the impacts of poverty in the community and what are collective strategies that we can implement across sectors to address issues of poverty. But my previous work has always been with maternal and child health. And early on in my public health career, I did, excuse me, I did an analysis in the state of Texas on the impact of maternal mortality and as it relates to inequities that we were seeing and how persistent that they were, especially for Black women. So I'm excited to be here and to touch, get back in touch with the role of maternal health and how it intersects with poverty. And I am also a student of Dr. Stephen Linder. He was a wonderful mentor to me, and I know he's been engaged in this work previously. So, hi, Dr. Linder.
And he's really been our rock and our foundation here in Houston for Cities Changing Diabetes Houston, and mapping out the epidemic of diabetes here in Houston. And so, as usual, he is incredibly amazing with his work, and passionate and motivating for those of us who volunteer here. So we also want to say a shout out to Dr. Linder again. And I love that we're talking about this in a Cities Changing Diabetes platform, because we are really focused on creating interventions that overlay community members, all members of the team. And I feel really honored to be here with the three of you, because here we have a public health professional with a clinician who works in the community, with a peer supporter who helps to guide people through their lives within their communities. And so I think that brings us to our first question, and then kind of how you all work together to get this done, or individuals in your different spaces do that. So why is Maternal, thinking about all of these things that we know, what the collective group of us know is important to helping someone modify and improve their health and their behaviors around their health, why then is maternal health such a challenge for women of color and for women of color living with diabetes?
Right. So I can just start by just outlining how major this situation is, and just highlighting that, even the United States, we have a higher rate of maternal death than any developing country. So that's a problem, number one. And then we look at our minority communities, our Black and Brown communities, particularly with Black women, there are 2 to 3 times higher risk to have severe maternal mortality during pregnancy, during delivery, and postpartum. And so there's a huge health disparity amongst minority women for maternal death, and for also neonatal death, somewhat interrelated. And this has been for several years. This awareness, this situation has been highlighted in the institutions of health for at least 20 years. And although maternal deaths are decreasing overall, the gap still remains with Black and Brown women in maternal mortality. And so women are just dying at much higher rates than their white and majority population counterparts. And there are definitely several contributing factors that relate to this. We know what increases the risk of death in general amongst Black and Brown communities, and that it often is related to chronic diseases like hypertension, obesity, and diabetes, of course. And so even with the higher risk of those in our communities, that also affects those who have those conditions or are at risk for those conditions when they're pregnant. And so just the risk factors of obesity and unhealthy lifestyle just put our communities at higher risk. And then there's all the other disparities in healthcare access, access to care, quality of care, unconscious bias that go into disparities that filter into this this problem as well for maternal deaths during pregnancy. And diabetes is a huge related factor. We know that those who have higher glucose and A1Cs, even going into before they're pregnant, during pregnancy and after pregnancy, have higher risk of complications and death. So it's really important to control those factors even before we call it preconception. So before you even thinking about being pregnant, you got to start living a healthy lifestyle. And that's, I guess, one of my roles as a primary care doc, is to really try to help people live healthier lives to reduce their risk. And this is one of them. Young women think they don't have a lot of risk. And that's another thing, you know, they think they're exempt from this, but unfortunately they're not. So we need to help them continue to be healthy even before they become pregnant.
Larissa, I want you to jump in here because I think that you were working, you were working on this before it became, more like a mainstream conversation.
Mm-hmm. Yeah, and it's interesting to have this conversation, and the idea of where you live, work, play, and pray, and learn really has become now a predictor for your maternal health outcomes, whether it be severe morbidity and mortality. And when we're talking about severe morbidity and mortality for maternal health, that's just the tip of the iceberg, and it really is a reflection of how the healthcare system could be better in responding to the needs of women, especially women of color, and particularly Black women who disproportionately experience implicit bias in the healthcare setting, and other biases that impact their capacity to access care. And that's a huge issue. And, Dr. Gadabecku, I'm thankful that you bring up the importance of preconception care and this idea of healthcare across the lifespan, and why access is so important, because what you're experiencing in childhood as you're a teenager, that all can influence how you then reflect as an adult living with diabetes or pregnant.
Yeah, I agree wholeheartedly. So you all know, and some of our viewers may know, if you're new, you may not. My specialty is diabetes during pregnancy. So I work with high-risk pregnant mommies who live with type 1 and type 2 diabetes, and as well as newly diagnosed gestational diabetes patients in our practice with my high-risk physicians. And so this concept of preconception and postconception and interconception, or between pregnancy care, is something that is not new to us. We're always encouraging patients to go see their primary care or their endocrinologist postpartum, so that coming into the next pregnancy, you come in prepared to reduce all of those risks as well. Serena, I know that you lived with diabetes during pregnancy. Can you kind of tell us a little bit about, those things that you may have experienced, and what some women are telling you in the community?
Well, personally, my pregnancy was definitely unplanned. I had been with diabetes for 5 years at that point. As I've said before in other shows, I was misdiagnosed as a type 1. And so I didn't find out I was type 2 until I was going to the doctor for my pregnancy. And so a lot of, I had to deal with, I had a regular OB-GYN. Then I had the maternal fetal medicine doctor. And there were some things that occurred that, they weren't on the same page. And I really felt like my OB-GYN there was a lot of women coming through there. So he kind of just wasn't into really getting down to what the issues were. And so when things would come up, there was not a communication between those doctors. And there were a lot of mishaps that happened during my pregnancy because of it. And a lot of it, I would say, is because there's a lot of things that I did not know. And I always say, I had maybe a couple, I haven't had that many pregnant mommies in peer support, but a couple of them they want to know everything, because now, it's different when you're just dealing with yourself. Now you're pregnant and you want your baby to be healthy. So now you want to know. And so they really just want, they want the information. They want to know what they need to do. I have heard a couple horror stories from Black pregnant mommies, and it's very disheartening because you hate to see someone else go through the stuff that they do, and it has nothing to do with them because they don't know the person they're putting their life in their hands. Is not really doing to their best ability, and they can't advocate for themselves because they don't know what to advocate for. So I think that has been a big problem, knowing, getting the information and the education to be able to take care of yourself and your baby.
Yeah, so now that everyone has outlined kind of the pre, the post, the during, I think one of the themes that comes up is the support. So what are we doing about this? You know, I know that we know that this is a problem, but how do we as communities tackle this? Are there you know, tenets and ways that problem solving skills that we can utilize to make it better?
Absolutely. I think the role of centering and centering prenatal care is a really critical way to start to bring in not just the individual pregnant mommy, but also the community that supports her, as well as starting to shift some of the organizational change. So we're thinking about the social ecological model and how on different levels can we impact a woman's health across her lifespan. And so with centering, it really is, it follows the same recommended schedule of prenatal visits, but instead of each visit being maybe 15, 30 minutes, each visit is actually 90 minutes to 2 hours. And it gives a significant amount of time with the provider, as well as with a supportive group of other pregnant women, to engage in their care by taking their own weight, blood pressure, recording their data. They're able to get private time with their provider, but they also engage with really a facilitated discussion and a safe space where they're able to build trust amongst each other. And it eliminates the power dynamics that often happen between a provider and a patient. And they get to talk about things that are really important. So those questions that you may not feel comfortable asking your doctor one-on-one, centering provides that space where you can ask anything and everything about what's important to you and understanding the process of being pregnant, managing your care, whether it be with diabetes, as well as also managing issues like stress, understanding labor and delivery, breastfeeding, infant care. All these things can get covered in these types of groups. And I would say that particularly for African American women, we've seen in Alameda County, California, there's an initiative called the Beloved Birth Centering Project, where it really is about bringing your people around you to participate in this collective visit. And that's something that's very different. I mean, everyone thinks that your relationship with your doctor is your one-on-one, but your relationship with your doctor is also with your family, with your friends, and with the healthcare system together. And so I really love the idea of centering and how it really just is a wraparound support for pregnant women.
And it sounds like it's it answers the questions that Serena had, right? So the questions that she may not have known to answer. It also addresses, the feeling of, well, I'm here, I'm one of many, and I'm not being heard. And so that has, monumental impact upon how someone can care for themselves, just in general, right, Dr. Gadabeku?
Definitely. A lot of what Larissa and Serena have talked about really relate to that therapeutic relationship between patient and provider that sometimes can be missed or not developed, underdeveloped. And I can definitely see in the prenatal space where, prenatal care, I remember when I was doing that, those visits were quite quick. They were, in and out. They were pregnant women, unfortunately, are often just seen, for better or for worse, as just healthy people that are pregnant, but and don't really have a lot of problems. So they can be quickly assessed and seen and, how's the baby? Let me listen to the fetal heart tones and okay, you're out, come back in 4 weeks, 2 weeks, 1 week, depending on where you are in your pregnancy. And there aren't those times to kind of really develop that relationship, that trust, and be able to feel comfortable and free to ask questions. If you feel something, you're concerned about something doesn't feel right. Um, and so, and I think another part of that too is even in the preconception space and opportunities where women aren't really going to the doctor as often because they're healthy, and so they're not developing that kind of relationship with a long term with a provider. And so sometimes the first time that a young woman is involved in the healthcare setting is when they become pregnant after not being seeing a doctor since they were a kid or at the most a teenager, and all of a sudden, like in maybe their late 20s, early 30s, they're like, oh, I'm pregnant, gotta go see a doctor. And all these the ease and the comfort of navigating healthcare system, talking to doctors hasn't really been developed. They haven't been seen. We don't even know where they are in their risks. We don't know what their numbers are, where their weight is, how they're being healthy or not healthy in their lifestyle prior to it. So really making this issue aware. I think that even though it's such a huge issue and it's been going on for so long, I still think it's very much underreported and people are just unaware at the ground level. I just don't think we know how great a risk there is. And then how important it is to get people to their providers on a routine basis prior to being pregnant, and then helping people to navigate the system while they are engaging in the healthcare system during pregnancy and after. And in that I like that inter-pregnancy, because a lot of times people get lost and kind of like, oh, I have a baby, I'm fine, I don't really need to see a doctor. And in between those multiple pregnancies, things are happening, bodies have changed. There's been pregnancy weight gain that's hard to get rid of sometimes, which causes increased risk. So I think there's just more education about this issue, more education about the resources. And I love the centering and having a little bit more time to have that connection with your provider and the healthcare team to really engage and address all the issues, social issues that contribute to these things, financial issues that contribute to these things, emotional issues, mental health, that also very much is interconnected with these things. So giving and providing that support is truly, truly important.
Yeah, and I would just add, we've talked a little bit about the individual as well as the centering care where you have multiple healthcare providers engaged, but there are also other policy and systems change opportunities that we have to start looking at, like expanding postpartum care beyond 6 weeks or 42 days and really looking at up to 12 months. And the reasoning for that is making sure that a woman is connected to care, but also women who are at higher risk for maternal mortality, they don't die in the first 42 days. They die within that first year after giving birth. And so being able to be connected to your provider, who, whether it be an OBGYN or a primary care physician, being able to engage with them on a regular basis on how you are recovering from your pregnancy. And I thought I saw a question pop up from a viewer on how can you talk about women who are at risk for developing diabetes and what they should be doing or talking with their physicians about? Well, I think that's it. It's just having the conversation. It's saying, I'm at risk because of, maternal or paternal history. I'd like to get an understanding as to what are the things that I can do before I get pregnant, whether it be, controlling your A1Cs already, especially if you have that high risk. And as someone that had pre-diabetes, it was something that was caught when I was in my 20s, and I had to monitor my sugar intake pretty early on, and I started to understand what those triggers were. And so being able to have that conversation with my primary care physician after they caught that was a really important piece. And so just starting the conversation with your provider. And if your provider does not want to listen to you, it is okay to change providers. And I want to encourage women to understand that you can change your provider at any time, especially if you don't feel like they're listening to you or providing the care that you know you deserve.
Yeah.
And
Yes.
so,
Yes.
Serena,
Yeah.
go
That's
ahead,
really
Serena.
important to have that therapeutic relationship with your provider. If it doesn't work, seek another provider.
Yeah, I'm an advocate for, go for what if you're not feeling comfortable, move around, and I think it's so important for that time period before you become pregnant, because as we all know, with the statistics are out there, there are millions of Americans who have diabetes and don't know it.
Yeah.
So that time before, that's the time to find out what's going on with your body before you even, try to plan for a family, or you're thinking about, having a baby. That's important, because a lot of things can happen in that time before that you don't know that you have diabetes. So you don't want your body to already be reacting to diabetes and you don't know it. Then, okay, now you're pregnant. Oh, now we're talking about diabetes and you feel blindsided. No one wants to go into something like that blindsided. Having a baby is a wonderful thing. You don't want any added stress. I mean, it's going to be some added stress, but it's not going to be like you were just knocked off your feet because you didn't know, you didn't check to see diabetes. What? It's like, well, actually you were in a pre-diabetic stage a couple years ago and you didn't know it. So yeah, that's important.
And I think that one of the key things is to prepare yourself and your clinician. So there are a lot of, you can have a conversation with your primary care to do, if you have a family history of diabetes, or if you have risk factors, you can check the risk factors for diabetes at the ADA.org site. You can do a really quick 1-minute question risk assessment. Go take that with you. It gives you some questions that you can ask your primary care physician. And a lot of times your primary care physician likely knows an OB-GYN that may be great for you, or a maternal fetal medicine physician, given your history, that may be a great fit for you. So having that conversation with your primary care is really important, because it gets you in the door ahead of time. And I know I'm a planner, and not everybody in the entire world is a planner. But I was able to interview a few OB-GYN doctors ahead of visiting with them. I also interviewed pediatric physicians before I took my kids to them, but that's the kind of person I am. But a lot of people don't know you can have discovery visits with your physicians, so that it's kind of like a quick round of dating, find out what, see what's going on, see if you jive, see if your philosophies about care are similar. And that way you're not just blindly going into a relationship with someone who's going to be delivering a precious life of yours. That's how I felt about it. But, it's kind of, it's case by case, person by person. In the Caribbean, like, people don't touch your kids if if you feel some kind of way about them. So so this is the person who's going to bring life to your life into the world.
Yeah, and I just want to add to that, the most common cause of death related to maternal mortality in the peripartum period, that means during pregnancy, during delivery, postpartum, and thereafter, is actually cardiovascular events like heart attacks, sometimes strokes. And these are things that, again, young, healthy people don't really think they're at risk for. but it's also things that we talk about, pregnant or not. When you come to the doctor, we assess your numbers, we assess your risk, we look at your weight, your BMI, all those things, and start to talk about, okay, how can we be healthier? And so those are the conversations that definitely need to happen. We have to have those opportunities to see, you know, let's get on a healthy lifestyle, healthy diet, exercise routines, and particularly if you tell your physician you're planning on being pregnant soon, or you're no longer on birth control, and you know, you can have those conversations about what that means for your risk during pregnancy and after. And then, you know, sometimes, like Dr. Larissa said, it may not happen right away, but once you have diabetes or gestational diabetes during pregnancy or elevated sugars, you have a lifetime higher risk of having those events. And so it's important not to kind of stay on top of your health after your pregnancy, not just like you said in that postpartum period of the 6 weeks, but years after it, because it can, even if it goes back to fairly towards normal, you will always have that increased risk in your later in life to develop diabetes in the future and have these cardiovascular events. And so just like I think a lot of us, when we talk about family planning, we talk about like birth control or not, prenatal vitamins, and like we push the prenatal vitamins, but we don't really push prescribing healthy lifestyle, you know. And so we need to do a better job of that in that family planning conversation as well.
Mm-hmm. And Larissa, you know, when someone Googles, so the other day I just Googled, you know, maternal health, diabetes, pregnancy. And one of the very first things that comes up, and I did it in like different sequences, right?
Yeah.
And every single time it came up, it was like poor control, death, mortality, like all of these things just kept coming up. You know, how is the community involved in changing kind of that dynamic for someone? Like, I think sometimes people come into it and they think I'm supposed to be very afraid, like I'm supposed to be very stressed. You know, what kind of role does the community and sort of messaging play?
You know, the community, there's the term or the phrase, it takes a village. And the village that we live in really does reflect how we care for our women, how we care for our children, and especially how we care for them when they're most vulnerable. And I really do see a role for community in advocating for stronger maternal health, uh, full spectrum care and coverage. I think there's opportunities to look at issues like transportation and how that impacts access to care, like living wages, and what that means in reducing stress for women and having insurance. I mean, that's a really big piece too. And these are all pieces that, as a community as a whole, we have to wrap around our most vulnerable, especially in these critical times of pregnancy, to lift up and talk and speak for them, because a lot of them may or may not have a voice in these spaces. I think there's also opportunities to better train up our healthcare providers, and not just your clinical providers like your MDs, but also what are the roles of midwives or doulas in providing those wraparound services. And that's very much more a community-centered approach, understanding the environment for which a woman is living in. How do you shift that environment that supports her during her pregnancy? Those are all important things that a nurse midwife or a doula can help support, just working with the family, working with the community, and understanding that and reflecting that.
I wanted to say, even in the midst of talking about all the other things that affect a pregnant mommy with diabetes, we all know that diabetes is all about decision making and setting goals. So I think it's important to also mention that some of these women even need to learn how to make better choices. I can talk for myself, some things wouldn't happen if you made a better choice with certain things. I won't go too far into that, but I know for myself that after I found out I was pregnant, I got a long talk from the women in my family about my decisions. So sometimes the decisions you make can compound your stress and can make a pregnancy more difficult because of certain decisions that you make. And so I think even empowering, even going as far as to the youth with the young girls, letting them know what to do, what not to do, try to think this through. This is not something that should just happen all the time, and that's how other problems happen. So I think it's important to note that decision making has a very big factor in the outcomes of a pregnancy as well.
Yeah, and I think that's why I like centering so very much. I think centering is an intersection of physicians. It's an intersection of midwives and doulas, nurses, the community health workers. Everybody's involved, centered around the individual. But like you said, Serena, it's really important to hear from other pregnant mommies, because walking through, and we as humans do this all the time, walking through the problems of someone else who is experiencing the same things that you have experienced makes the decision-making process more clear. Instead of just, me saying to someone, well, these should be your decisions, having someone who's sitting in front of you who's also 26 weeks pregnant saying to you, I made this better decision and better things happened, is so much more impactful.
Definitely.
Yeah, it's important to have that peer-to-peer interaction. And I think also that just the supportive nature of the other clinicians around you to be able to answer those questions that you might have, whether it be, how do you access high quality foods? How do you get on WIC? Like things like that are very things that if you don't know, you don't know. And if you've never been trained up or connected into that kind of realm of accessing elements of the system to support your livelihood and your care, then you wouldn't know where to start. But when you're with peers, you're in a safe, trusted space where you can ask those questions, get connected to resources, and it really becomes that warm handoff that many of us seek within the healthcare setting, is being able to know that if I'm going to this person or this place for whether it be my prescription or other needs, that I know I'm going to be treated well. And that's that trust that is really developed within that centering approach.
And can we talk about the patient? So the patients benefit, but can we also talk about the clinicians, for the clinicians who are listening? Because I think there are things that we hear from patients talking to patients that can lead us to think, oh, perhaps these are the questions we need to ask them based on what they're saying that they're experiencing to someone else. Like, can we talk about just that, knowing a little bit more about the patients and how that improves, provider resiliency and the sort of the confidence we feel when making decisions for our patients?
Yeah, I mean, I think what I hear when you're asking about this is just really digging into social determinants of health, and just asking those questions about what Dr. Lissa mentioned, where you work, live, learn, play, pray, your environment, all these factors in your life, your financial situation, your social situation, where you're living. Do you have housing insecurity? Do you have food insecurity? Are you worried about where you're going to have your next meal? Are you able to have home cooked meals? What are you balancing between taking care of yourself, taking care of your children, taking care of your household, and actually neglecting your own health? Like, just really digging into the contributing factors of someone's life that affect their health, affect how they, engage even in the healthcare system. Like they may not um, go to their visits because not because they just don't care, but because they're working 2-3 jobs, or they're taking care of their family. They don't have that, they feel that they don't have that time to take care of themselves. Transportation, like you mentioned. So the things, the non-medical questions that we often forget or neglect to ask to really assess people's situations, conditions, modifiable often factors, things that we can say, okay, we discover and we can get support and resources. So we really, and I know especially me in training programs, and we're really trying to teach our clinicians, and that's across the board. That's, physician, medical students and trainees, but nurse practitioners, but physician assistants, social workers, case managers, nurses, all the people that are part of the care team that really are a part of this conversation and need to kind of delve into those determinants of health that can be modifiable, or at least areas of support. And again, not having those quick in and out visits. Okay, you're healthy, baby's good, see ya. But like really asking those really crucial questions to assess the whole person, and making sure that they're physically okay, mentally okay, emotionally okay, financially okay, socially okay. So.
Yeah, and I would just also add to that that some patients that might have a difficult situation for which they're living in may often be looked at as non-compliant because they don't follow through with reducing their sugar intake. But, what if they live in a food desert and don't have access to nutrient dense produce, fresh produce? I mean, those are things you won't know unless you ask. And I think the approach of having the providers and the benefit of having providers within a centering model is that they can start to learn and hear about those environmental impacts, and how, if you understand that they're not lowering their sugar, but what is the impact behind that? What's sitting behind that? Is it because they don't have a car to get to the grocery store? Or, the grocery store is what, an hour and a
Too
half bus?
far.
Yeah. And,
Mhm.
these are things that you don't take into account because your own privilege a lot of times negates that. And you're like, well, what do you mean you don't have a car? What do you mean, you don't have enough money for food? Those are things that can come up in these natural spaces. And in a 15-minute office visit, you're not going to get that.
Yeah, and I was just about to borrow your phrase when you were talking about patients, if they don't know, if you don't know, you don't know. But the other side can be true too.
Mhm.
Those of us who are supposed to provide care, if we don't know, we don't know either. And we don't know what a person needs. And
Yeah.
if the time doesn't allow it, if the power dynamic doesn't allow for the conversation, or a trust to be built to have a conversation, you may never know what your patient is struggling through. But I think in a safe environment, in a peer support safe space, a lot of this comes up, and there's nothing more rewarding than to have a mom return, postpartum, and say, we do in our clinic, we help. While we don't yet have centering, we have a case manager and community health worker, and of course, our diabetes care team members who speak to patients about postpartum care.
Mhm.
And then we have primary care physicians who are fantastic, and endocrinologists who will schedule our patients ahead of their delivery so that they have a scheduled visit.
Right.
And when some of these moms come back, they're in a better space than they were the second pregnancy, than they were the first pregnancy. And I have another mom who's in her third pregnancy, and she's with me, and she's in a better space in this third pregnancy than she even was before. And so I think that, you know, just having a conversation about the importance of policy change
Mhm.
so that the members of the clinical team centered around the patient get legs in doing programming like centering, you know?
Yeah, I mean, I'd like to reference one a suite of legislation that's being worked on here in California, Senate Bill 65, which is also known as the Momnibus, which is a comprehensive piece of legislation that really is looking at emerging or reimagining what maternal health can look like. And really, at its core, it's about reducing the racial and socioeconomic disparities gap that we see in California. And in California, over the last several years, we've been able to dramatically reduce maternal mortality and severe morbidity, but there's still a persistent gap between what Black women experience versus other women. And so the Momnibus is looking at issues like expanding the power of the Maternal Mortality Review Board to really look at other racial and socioeconomic disparities, the expansion of postpartum care to 12 months, and that's something I mentioned earlier, looking at other requirements for public programs and reducing those burdens. Those are other big policy changes. Um, Full spectrum doula coverage. So in addition to coverage from your primary care provider, your OBGYN, also ensuring the coverage of doulas or that supportive care network. And another really key piece of this legislation that I absolutely love is the idea of guaranteed income. And we know that guaranteed income is kind of the hot thing now, thanks to Andrew Yang and his presidential campaign run. But guaranteed income is really an important intervention that can have a lifetime of effects. And we've seen pilot projects in Stockton, California. We've seen pilot projects in Jackson, Mississippi with pregnant women. And we even have one in the San Francisco Bay Area where it's providing a universal basic income for a period of time to low income families. And data time and time again has shown better outcomes in health as well as financial stability in a short amount of time. They're using the money for food, to cover the cost of fixing a car so that they can get to work, utility costs, rent. They're even establishing savings. And so there's this really opportune time to look at policy and reducing that financial strain. And this is something that is really coming up now just because of the economic downturn due to the COVID pandemic. But the chronic stress that financial strain puts on an individual, let alone a pregnant woman, has a real documented relationship with preterm birth. And so it's not just one thing to focus on the care, but you've got to, again, wrap yourself around the woman and look at those policy opportunities, whether it be, I forget the name of the shot, but the administration of the shot for preterm birth, if you've had a preterm birth before, like that's a medical intervention. But looking at financial security and how do you support that with a woman, that's another layer that just provides that ceiling, that floor of support during this really critical time. And policy change can do that.
Mm-hmm. I think this is it's Congresswoman Alma Adams and Lauren Underwood. And you can find out more by going to Black Maternal Health Caucus -underwood.house.gov. So, or you could just Google. That might make it easier. And then you find all of the details. Oh, look at that right there for you.
And I just want to highlight how important it is for these policy changes to break the cycle. There is a huge cycle here. And as Dr. Larissa mentioned, preterm birth, we know actually that preterm people who were born preterm have a higher lifetime risk of cardiovascular disease and diabetes. And so that's just that's a cycle, and that they're going to be at higher risk for all these things that we're talking about. And so that's why we have not been able to break the cycle. The maternal death and preterm death, preterm birth and neonatal death is improving across the board, but not for our communities. And there's that cycle there. And we really need to push to break the cycle.
Wow, I'm so appreciative for the three of you for being here today to talk about this. It's so very important. And, you know, I live with caring for mommies every day. And it is something that I'm wholly passionate about. And it's conversations like these that I think need to be had amongst people who don't know that it's going on, so that they can help drive policy change too. So to our viewers out there, patients, family members, clinicians, doulas, you know, get behind the policies and advocate for these policies. You know, give your voice and a signature to that. So, is there anything else you all would like, you know, a call to action before we head out?
I guess the biggest call to action I have, especially for the pregnant moms out there that may be managing diabetes in addition to a whole host of other things, is to be gentle with yourselves. You know, you've only got one you, and it's critical that if you're not gentle with yourself, that'll start to cascade into other aspects of your life. And being gentle with yourself is really about self-care and caring for yourself, and asserting yourself when appropriate, as you need to be your own advocate as well. But also for those that are out there around women, advocating on behalf of women is really important too.
Yeah. I think, you know, I think if we're asking people to stand up for themselves, we have to be here to stand up with them.
Absolutely.
And so I think, you know, if you see policies in your clinical practice that you can impact, raise your voice, even, you know, even if it's, you know, that good trouble that you have to create, you know, ask for more help. Get the paperwork and the documentation together to create a plan that is, you know, spoken from a business standpoint. You know, say a community health worker can help us in this way, a doula can help us in this way. Can we add them to the team? The answer may not be yes today, but you've started the conversation, and it may be a yes tomorrow. And in that way, you're advocating for people so that there'll be more voices behind you, getting louder and louder as you grow together.
Right. And my call to action is just to have these more conversations, because conversations bring out awareness and help to make the moves to make change. And in your respective circles, a lot of times we think this is like so big and so beyond us, but we all have spheres of influence in whatever that is. And so even just having conversations like these are so important. And then just taking care, like as Dr. Larissa said, self-care, care for yourself. We as women, once we have another life, then we start, oh, gotta take care of myself from a baby. But really start taking care of yourself, and focusing on your health, and taking time to love you and be healthy. Be healthy for you if you can. Just be healthy for you and have these conversations.
I would just say, you know, it doesn't, I always tell people, it doesn't take a college degree to do research. We have so many things on our fingertips. And if you feel uncomfortable, not because the physician has made you feel uncomfortable, but you just feel uncomfortable talking about your situation, bring someone with you to your doctor's appointment. Talk to that person and say, hey, I really don't feel comfortable saying this. Can you ask for me? There's nothing wrong with doing that. And if you don't have someone that'll do that, hey, we have a diabetes peer support program here in Houston. Shameless plug. So if you go on Facebook and you type in the search engine, Houston Diabetes Peer Support Program, follow us, please. We will, as soon as you join, we'll know you in the group. You can post questions. There are people who are there to help answer your questions. If our peer supporters cannot answer your questions, we will definitely find someone who can answer your questions. And we're always here to support people living with diabetes.
Yeah, so use those connections, y'all. That's what we, I think, as communities do for a lot of other things. You know, we have, I'm going to get my car fixed. Like, you ask other people about the who I should go to if you're trying to hold a party and you need a hostess or something. All of the things that we do in life, we have supporters helping us, and I do not think that pregnancy should be any different. So again, we do have a shout out because we have some viewers all the way in Europe, even across to Indonesia. Hi, everyone out there. And all across the US, coast to coast. I love that we have, this sphere of influence that we get to reach so many viewers and so many people. We are super, very, very, very grateful for you. And Tara in Alameda, California, for your great question. Thank you as well. I hope you reach out to your primary care and interview your prospective OB-GYN, or your friend does that. And also Nita, who's watching out there today. We're here to support you as well. So again, thank you, ladies, so much. I really hope that we can continue this conversation another day, perhaps with a new set of viewers, a new set of questions, maybe with a message of passage of the Momnibus. So, that day would be a great day, indeed. So I hope you all are open to coming back and having this conversation again.
Absolutely. I would love to.
All right. Thank you, ladies.
Bye.
So
Bye.
we have Dr. Larissa Estes White, we have Dr. Annette Gadabeku, and we have Serena Valentine, peer support extraordinaire. Thank you all. I'm just in awe of all the things that the three of you do.
You too, Joy.
Thank you, Joy.